Okay, team, we're going to start about 10 minutes early. Apparently the bell went off 15 minutes too early, but everyone was well behaved and came in within 5 minutes. So if we start now, we'll be finished at 10 to 5. So I'd like to introduce Allan Cyna for the last session of the day. Personally, I felt it was funny having a workshop without actually having a workshop, because we've had these pre-conference workshops for years, but there's never been a workshop in them as far as I can remember. So I thought, well, stuff it, let's have a workshop within the workshop. And because we're in Adelaide, Allan's here. He's internationally recognised as being expert in paediatric and obstetric hypnosis literature. And I'm really looking forward to his session. And also big thanks to Rob, who's come along as well to give him a hand. Thank you, Allan.
And thanks very much for inviting me. Sue Tan's at the back, and she's done the hypnosis course last year. She's been pain medicine for a number of years, so hopefully she's going to help out as well when we do some of the practical stuff. My hypnosis thoughts really began as a medical student. In the second year, we had a 75-year-old retired anaesthetist, Dr. Johnson, who was giving an evening lecture to 200 medical students. And he drew a circle on the blackboard with a cross through the middle of the circle, and he asked people in the audience to focus their eyes on the middle of the circle. And then within about 30 seconds, I felt my eyes becoming cataleptic. I felt myself drifting into a bit of a daydream. And at that point, I could hear him say, now the rest of you can come out of that daydream, return to the room, because we've got 6 or 7 people in quite a deep hypnotic trance. So I sort of vaguely woke myself up, and lo and behold, there were 6 or 7 of my colleague medical students who I'd known for a couple of years who looked like they were asleep. And he proceeded to give them suggestions of that they had a helium balloon attached to the arm and their arms floated up. And then he gave suggestions for an anaesthetic glove where their arm became anaesthetic. And then he proceeded to go around each of them and stick needles, several needles, in fact, through the arms of these cataleptic, arm-levitated colleagues. And I found that quite interesting. And so that was really my first exposure. And I initially started as a general practice practitioner. But that always was with me in the back of my mind. When I came to South Australia, as an anaesthetist, Graham Wicks, who had been doing hypnosis at the Women's and Children's for many years, and he's probably one of the very few medical doctors who was employed by a hospital worldwide, and he actually did clinical hypnosis with children for over 30 years in Adelaide. And if you go to Sweden or America or Canada, everybody knows Graham. But interestingly, no one's heard of him outside the Women's and Children's and in non-hypnosis circles, which is really interesting. Anyway, why have I got a picture of a functional MRI of the brain? I'll talk a little bit about that later, but it's just really showing we can image how words affect the brain in terms of giving a suffering component to the sensations we're experiencing. The Patient Sedation Without Medication book is written by Elvira Lang, who used to be Associate Prof in Radiology at Harvard. And it's a really lovely book about how to talk to patients and just with communication inducing analgesia and relaxation. Angela Mackenzie is a paediatrician in Melbourne. She used to work in the sick kids in the acute pain service there. And she's written a wonderful book, Everybody Stay Calm, how to talk to children having painful procedures. And then we've got our book there. James Braid was a surgeon from 150 years ago, a Scottish surgeon who described hundreds of procedures actually under hypnosis before pharmacological anaesthesia came along. And then we've got Harry the Hypnopotamus. I don't know whether some of you have seen that book, but it gives lovely metaphors for children in all sorts of difficult situations. So definitely worth having a look there. Okay. So that's me. I've told you who I am. And I work primarily at the Women's and Children's doing paediatric burns on the children's side and obstetric analgesia on the other side. And interestingly, pregnant women and children as a group are probably the most hypnotizable groups you can have. So Women's and Children's Hospital is a pretty good place to work if you've got an interest in hypnosis, because you've got a very high hypnotizable population in that group. Now, has anyone here had some exposure to hypnosis training? I know a few of you have. 1, 2, very great, yeah. So what exposure have you had?
I've read some papers, done some stuff as a pediatric anaesthetist, and made a couple of workshops.
Great. Okay.
Still feeling very nervous.
Okay, great. So what I thought, look, obviously a lot of people, especially in the pain relief field, I'm not going to talk about the pain field, I'm going to talk about the pain relief field. A lot of people will be bringing skills and resources and using hypnotic techniques, sometimes without realizing that's what they're doing. And often through many years of experience, we do develop language structures that seem to be working better than others. So I'm hoping you're going to bring those here and let me learn from that. And in terms of goals, from my point of view, and I'll just check with you whether you're okay with this, what I was going to do is just try and minimize the lecture type stuff and go through, I'll show you some videos of how we're using some of this stuff clinically. But what I'm really interested in is just giving you a flavour of how to do two main techniques. One's called the steeple technique. Anyone heard of that? No. And the other is called lived-in imagination. Has anyone heard that? Good. Excellent. So there's 2 techniques. They're very easy to do. They take about 3 minutes to do, and they're very easy to learn. So I thought we could actually go through that with you, show you some clinical cases, do that, and then practice it as part of the workshop. Actually do a workshop, which is that okay with everybody? Yeah, sort of. So we're going to talk about some evolution. Why do we have this ability? Everybody has this ability to dissociate, go into trance. Some of you are in hypnosis while I'm talking. You'll dissociate, you go into a bit of a daydream, thinking about what's for dinner tonight or whatever. So you're transiently in and out of hypnosis 100 times a day without even realizing it. And what do you think the evolutionary advantage might be of going in and out of hypnosis? Anyone? Rest the brain, possibly. But there's an actually evolutionary advantage to this ability we all have of going into trance-like states. Sorry? Hibernation? Not really. Well, it may be, but I'm not sure they're the primary ones. What do you think? Anybody else? Have you ever cut your finger, not realised you've cut your finger until you've looked at it and then suddenly it's really sore? Or stubbed a toe, got a heap of people coming for a barbecue and then only realised it was broken after everybody's left or something like that. So that's happened to me, by the way. So, yes, dissociation from pain, so you can escape from pain. In catalepsy, where you can lie rigidly still, escaping from danger. Other things, decreased bleeding. There's some interesting evidence. We've been doing some experiments with this, where bleeding can be decreased in hypnosis. And we see this all the time when we pop drips in people who are in these trance-like states. And the other thing is reducing infection. So if you can imagine 100,000 years ago, spear goes through your shoulder, and you want to escape from the tribe that's chasing you, dissociation from pain, decreased bleeding, reducing infection would all be really useful advantages. And we see all those things in terms of white cell activity, changes in the bleeding state. And we've got some evidence of this. And in fact, hypnosis was a treatment for haemophilia before factor VIII came along. So there you go. So that is maybe our thoughts on that. So we're going to talk primarily about the steeple and believed in imagination. And if we've got time, we'll just show some switchwire imagery for those of you that haven't seen. How many of you have seen the switchwire imagery before? A few of you. So we may or may not have time for that, but it doesn't really matter. And this is Michael Nash, who's president of the American Society of Clinical Hypnosis a few years ago. Very skeptical reporter from Scientific American came to have a chat with him about hypnosis, and he said, "Oh, look, would you like to experience it?" And it turned out that she was highly rated on the standard hypnotizability scales, and in fact was in the top 10% of hypnotic capacity subjects, and was able to have a whole host of hypnotic phenomena such as anesthesia, amnesia, catalepsy, and hallucinations. So a whole series of hypnotic phenomena were able to be demonstrated. So she wrote quite an interesting piece on that. This is Graham Wicks. I'm just going to play you about 5 seconds worth because he does go on a bit sometimes, but he's lovely. He's really one of Australia's national treasures, and he still teaches on the South Australian hypnosis course, so we love bringing him out and just giving some of his anecdotes. But I'm just going to let you hear him a bit.
Now, another thing that hypnosis is communication with what we call the unconscious or the subconscious mind.
I'm going to just stop him there because we're going to practice some of this stuff. So communicating with the subconscious, and whenever we communicate with anybody, be it adults or children, we're communicating at a conscious level, a logical level, but vast majority of our communications are subconscious and eliciting subconscious responses. And this can be in terms of pacing of your language and body language and all sorts of other things. We're going to talk more about language than the actual non-language stuff today. But anyway. But kids respond incredibly well to metaphor, obviously storytelling, metaphor, and so on. Now, we've all experienced these subconscious experiences, being in two minds about something, and the classic is the needle phobic, where the logical mind's brought them into hospital to have their blood test and drip or whatever, but their subconscious mind is trying to get them to escape, and they just can't bring themselves subconsciously to do it. So this conscious-subconscious dichotomy, mostly the conscious and subconscious are working synonymously and synergistically together. Sometimes when patients are extremely stressed, they're beside themselves, they get out-of-body experiences, they get daydreaming, and we often tune out, especially if two people are talking simultaneously. It's a great way to go into hypnosis, is two people just shouting at you, giving you commands in one ear and the other ear, and you just dissociate and become internally focused. And a lot of our patients, there's so much external stimulation, to escape from it all, they start focusing internally and they get this absorption. So they go from extreme terror to a sort of glazed look, and then some sort of calmness comes over them. So I'm not going to spend any time showing the video that shows that anymore because we've got too much else I think we should do. So as an anaesthetist, we're constantly thinking about safety, comfort, not much about control or choices, but from the patient's point of view, and this is adults and children, they want to feel in control. And a lot of the other things are, in a way, out the window. They're feeling completely out of control. They're victims to their illness. They're victims to incomprehensible technology, pharmacology, and they want to get some perception of control, even if it's only a perception of control. It doesn't actually have to be real control. They want some choice. I mean, they are interested in comfort and they are interested in safety, but it's not focused on nearly as much as trying to get some control back in their lives or in what's happening to them in hospital. If Karen Olness in the 70s, if you can get this paper, it's fantastic. It's really good. Some guidelines for use of hypnotherapy in pediatrics. And Olness and Cohn have written the definitive book on hypnosis, hypnotherapy in children, and Sugarman is the other book that's around that's really useful. But just having a look at that 1970s paper, it's as relevant today as it was when it was written nearly 40 years ago. So that's definitely worth a look. I thought, just to sort of give you a flavour of the sort of stuff we do, this is Max, who's 90% burnt, and one of his first dressings on the ward. He was in hospital for 9 months and intubated for nearly 100 days. And this is one of his first dressing changes of his hand. I'm just going to do some deep breaths with you. You don't have to do anything, all right? So I'm going to do a deep breath with you so we can just get this dressing finished a bit more comfortably. Is that okay? Is that okay if I do the deep breathing with you? Is that okay? Okay, he couldn't talk, so what we did was set up what we call idiomotor finger signals, and we call one finger the yes finger, we call one finger the no finger. And we just get him to practice a yes, he lifts the yes finger, and a no, he lifts the no finger. And then in this sort of state, children actually function non-volitionally and subconsciously. So you're actually not talking to the conscious mind at this when you have very stressed children. You're actually talking to the subconscious mind. And most children in a subconscious frame of mind most of the times anyway. But those fingers were moving in an idiomotor way, a non-volitional way. Nice, okay. So I'm going to just do the deep breathing with you, okay? Ready? Okay, so I'm going to do the deep breathing with you. This is called an indirect suggestion. You don't have to do anything. There's nothing you need to try and do. There's nothing you need to think about. It's just going to seem to happen all on its own. So I'm not asking him to do anything. When people are stressed, they can't cooperate logically with their care. They can only do things in an illogical way, in a non-volitional way. So I'm not asking him to do anything at all. All I'm asking him to do, all I'm saying to him is, I'm going to do the breathing with you. The suggestion is, you're going to now do the breathing. Okay. Steady. Here we go. I'm going to do a deep breathing with you like this, look. I'm going to hold it for a couple of seconds, and then I'm going to blow away some of that discomfort into the atmosphere like this. We're going to carry on while we do that. Ready? Deep breath in. Deep breath in like this. You don't have to do anything. I'm going to do it, help you, for you. I'm going to blow away now. I'm going to just blow away some of that discomfort into the atmosphere for you now. Well done. Well done. Do you know, those dressings are very nearly done. We're just putting those nice cotton wool dressings there so that they can start feeling nice and clean and nice and comfortable for you when they're done. So you're doing really good. And this is going to help the skin heal and recover a lot quicker than it would do otherwise. Okay. Okie doke, let's move on. Yeah. So we've talked a little bit of why we have a subconscious, and we've just been doing some experiments at the Women's and Children's on hypnosis and bleeding. And what we do is we get volunteers like orderlies, nurses, consultants, to go into hypnosis. We guide them into hypnosis, and then we suggest arm anaesthesia, and then we stick 23 gauge needles through the skin in the back of their hands. And we've got a video camera and an infrared camera measuring temperature change and microcirculation, what we think is microcirculation change. And then we suggest that one arm comes out of hypnosis, one arm stays in hypnosis, and we look for differences in bleeding. So you just start feeling all normal sensations in that left arm as you've taken the anaesthetic glove off. And just notice it, all the muscles and ligaments will just return to normal, and you'll just get all the nerves feeling normal in that arm. And when you're feeling that arm completely normal, as fully as it can be, the yes finger can lift up. You can let me know with the yes finger. When that arm feels completely normal, that left arm feels completely normal again. Normal sensations returning. Beautiful, well done. Okay, we're just going to give it another 15 seconds to come back even more. And then we're going to do a free count again and just remove those two. So, you all okay? So it's 3, 2, 1. So all normal sensations in that left arm can come back completely to normal. So all the muscles, ligaments, blood vessels, everything, the anaesthetic can just drain away. It could drain away into the pillow, it can drain away into the rest of your body. But wherever it goes, it'll be out of that arm completely. And when it's out of that arm completely, the yes finger can lift up and let me know. Beautiful. Okay. So we'll just give that another 15 seconds to fully drain any remaining bits of anaesthetic out. And then we're going to remove those 2 needles. Okay. 3, 2, 1. My friend Kevin, the neurosurgeon, calls this the freaky deaky stuff, and he tries telling me not to show it to people. Anyway, okay. Angela Mackenzie, paediatrician I was talking about earlier in Melbourne, sent me this email a couple of years ago now. A friend's son with haemophilia has been bleeding from his finger for 6 weeks. In spite of treatment, told her about the bleeding study, and they want to bring the kid to Adelaide. And I wrote back and I said, try some believed in imagination, ask the boy to switch the bleeding off, close the tap, whatever the boy says needs to be done. And then the next day she writes, hold on, what did she write next day? Here she goes. Bleeding stopped as soon as the mother told him he could stop it. So it was interesting that children, as I say, can actually respond to suggestion in what they seem to be in the awake state, but they're constantly in this daydream type thinking, this imaginative state, and suggestions will frequently get realised, especially if they're associated with the imagery and the imagination. So you can do hypnosis by email. So prone to fantasy, as you know, there's little reality testing. They actually respond to authority generally, parents. They frequently, as we've talked about, respond subconsciously, extremely responsive to suggestion. And suggestions are these communications that lead to non-volitional responses, be they in perception or behaviour. So we'll just sort of, you all know what we're looking for here, and certainly pharmacologically, a lot of these things are made worse with pharmacology, and yet hypnosis and the way we communicate can dramatically improve what we want to do with patients in their care. So one of the things I frequently ask patients is what they like to be called. Often their name on the name sticker isn't what they're known by, and people often do have a preference, and this is true for adults and children. And I often ask them what their friends call them, and then, is it okay if I call you that? Just to sort of ask permission, give them another, it's part of that rapport building, getting them to feel they've got a sense of control of what's happening to them. And so that's actually quite important, I think. And also asking their permission to talk to a parent. So initially talking to the child, I actually say now, is it okay if I just have a quick chat with mum? Or is it okay to have a quick chat with dad? They always say yes to that. They never tell me no, I'm not allowed to. So that's good. Okay, so this is the first exercise we're going to do, and some of you will have done this before if you've been to workshops with me before. But what I'd like to do is to just sit next to somebody, preferably who you don't know, and I want you to ask them two things they like doing and a favourite food or drink they like. So can you ask them their name, what they like to be called, okay? Two things they like doing and a favourite food or drink they like. And then I'm going to ask you questions about it. We're going to spend a minute just doing that, and then we're going to reverse roles. So there's two of you sitting next to people you don't know. Okay.
Hi.
If you haven't swapped over yet, just think about swapping over in the next 10, 15 seconds. Okay, we're going to wind this up in about 10 seconds, guys. Okay, so we're just going to do the what do you think feedback on that. Okay. All set? All set? Okay, good. Okay, what did you notice about that, first of all? What did you notice about that? Volume went up. Why was that? Sorry? They were happily chatting, so positive affect. The volume of the room went up. There's a lot of engagement. There is a lot of excitement. Kids love telling you what they like doing, and they love telling you what they like eating, and they love telling you what they like about anything. So it's really interesting, and the child in all of us loves that too. I mean, we all like telling people about what we like, what we're interested in, but children especially so. And so it's a really good way of gaining rapport. It's actually the first question I ask a child after their name and how old they are, is tell me your favourite thing you like doing in the whole wide world. And what's your favourite colour? And tell me what you want to eat after you wake up from your anaesthetic or wake up from your operation. What do you want to eat? What's your favourite thing you like eating? That's an anti-emesis suggestion. Tell me what you're going to eat as soon as you wake up. Tell me what you're going to drink. Okay. So, I'm just going to ask a few questions. The girl in the green. Can you tell me the person next to you, what she called and two of her favourite things and what she likes eating?
Maddie?
Yes?
What are two of your favourite things she likes doing? Chris likes walking and shopping.
So Maddie likes walking and shopping. Okay. Maddie, and tell me about the... Yeah. Adelaide?
We like
Watching movies.
and she likes inside.
Very good. That's okay. We're going to move to, okay. How did you go? Janine likes gardening. Champagne. Okay. Okay. Matt likes quad bike riding and skydiving. Excellent. And who was talking? Yeah, go on. Okay, so what have you noticed? I mean, we're not going to go around the room, obviously, but what did you notice about those responses? They're very varied. So one of the issues is when you ask kids to imagine something or think about something that you like, it may be nothing to do with what they like. And so, it's amazing what kids and adults will tell you that you think, how can you possibly like that? It's like horrible, you know. But then it's actually, they like it, so they like it. So that's good. So it's a really useful, so there's a huge variety of responses that kids give you when you ask that question. And that's interesting. And you can ask them and they can give you a lot of detail. Salad sandwiches with extra mayonnaise and onion. Okay. So we've got a bit of a communication structure which we use for both adults and children. And it's called the laws of communication. And it's really the laws of hypnotic communication. And the L is listening. And it's listening, but it's also looking and observing what's happening. And it's not just listening while you're thinking of what you're going to say next. It's listening exactly to the words they're using, exactly to the very words they're using, and listening for meaning, and then checking in with them that you've heard them correctly, and then checking in with them that you've understood what they've meant by what they've told you. So it's saying, so are you meaning to tell me, or do you tell me really that you like onions in your salad sandwich? Are you really telling me that? Yeah, okay. No, I don't like onions at all. I like something else. Okay, better. Okay. Acceptance. This is what we heard a little bit this morning about. Acceptance is really accepting where someone is at that point in time. And I know as pain physicians, pain relief physicians, that you and healthcare staff working with children with pain, that you're very focused on just accepting this is where they are. But we find a lot of people have real difficulty with this. And it's not a matter of buying in to where they are. It's just a matter of accepting this is where they are so we can move on from it, rather than accepting that it's reasonable. I mean, you can still think it's ridiculous, just don't let them know. So you can think whatever you like, but it is that acceptance. This is where we are now, and I believe you, I accept this is the case. Let's move on for it. A common one we see all the time is the severely needle phobic, where they'll come in to you for your blood test and then you show them the 24 gauge neonatal cannula, and they'll describe it as a horse needle piercing my skin, or a molten sword passing through my body. So there's a reality there that isn't congruent. It's a subconscious perceptual reality that's not congruent with, and this is the fact that they've still got the tattoos, the nipple rings and whatnot, but it's nothing to do with the perception, it's to do with the perception of the process. Utilisation. A lot of what we've done already can be utilised. So, we've found out what the child likes to be called. We found out the favourite thing they like doing in the whole wide world, the favourite colour, what they're going to eat and drink later on. A lot of these things can be utilised, and often kids, when they come into theatre screaming or whatnot, you can often say, now remind me, was your favourite colour blue or yellow? And you know damn well it was red. But no, you know, they'll go, no, it's pink, or it's red, or it's green, and then they'll be distracted enough to engage. So utilization is a key aspect of hypnosis, and utilizing what seems to be the problem and reframing it into a solution. I had a child one time who came into the MRI suite holding his nose, and the parent, 4-year-old, holding the nose, the parent was doing this, and the child was doing this, and the parent was doing this, and the child was doing this, and everyone was getting more and more anxious. And I just asked the parent if they would let the child squeeze his nose. And I just asked the child to squeeze your nose, feel the sticky glue on the ends of the fingers. And the glue's sticking, and it's sticking, and it's sticking, and the fingers are becoming more and more sticky, and the fingers are stuck to the nose, they're stuck to the nose, and then the child was asleep. So you can often reframe and utilize what seems to be the problem and then turn it into a solution. And suggestion. We're going to talk a little bit about suggestion. So we've talked about listening, and it's also the parents as well, obviously. I mean, have you actually understood what the parents have said? And do they know that you've actually understood what they've meant by what they've told you? And it really does involve this checking in, checking back process with parents. Okie doke, let's go. So, what's the first reality? Those of you that want to answer that? And understanding realities can be quite helpful. So the first reality is actually our own. So now you know that, what's the second reality? The child's. So the child's reality, and that obviously can be very different from our own reality, and very different from what we perceive the child's reality to be. So that's the second reality. What's the third reality, do you think? Sorry? Well, the second reality is any person you're interacting with, and that actually includes the parents. So you've got your own reality, and when you're talking to the parents, that's really the second reality. But there is a third reality that's taken us probably a while to actually appreciate. And it's actually the 6 billion other realities on the planet who you aren't interacting with at that time point. And it allows your mind to free up to appreciate that when you think you've done everything, tried everything, thought of everything, there's nothing more you can do. There's 5,999,000 things you wouldn't have thought of because you're not that person, you're not the other people on the planet. So, in fact, there's billions and billions of other ways of doing something, even when we think we've tried everything. And often, recognizing that third reality just brings into our mind subconsciously a lot of alternative strategies that we haven't thought of, and we're only really limited by the imagination and then how we interact with people. So you can often combine, as you do this, this then happens. So when you ask a child to do something, lift their arm in the air and then bring it down, or as they breathe in, they can breathe in some strength. As they breathe out, they can just blow away anything they don't like. Or as they think of their favourite colour, they can just watch it change as they feel more and more relaxed. Or so there's all sorts of things you can do that can, as you do this, you can see this, you can feel this, you can find this happens without you thinking about it. Nothing you need to try and do, nothing you need to think about. Just linking in perceptions and experiences that might be acceptable to the child. So there was a girl I saw in the ICU a few weeks ago, and she had all these burns on her face. It was only a few days after the burn, and when I came in the morning, she was screaming in the ICU that her face was on fire. And her parents had been saying, oh, you know, and the nurses had been wanting to give more drugs, and the parents were sort of beside themselves. And I just said to the girl, would water help? And she says, yes, cold water. I says, okay, we're going to get this big bucket of cold water, and I'm just going to pour it all over your face. So I went over to the side of the room, and I picked up this imaginary bucket of water, And I just came over to her and I just started pouring this imaginary bucket of water on her face and says, "Is that feeling better yet?" She said, "Oh, God, so much better, thank you." So I'm not suggesting you pour a bucket of water over someone's face in the PICU, but you can do the imaginative bucket of water and it will help. It can help, not will. But she was in such a non-logical frame of mind, even though she was 10. It was a real bucket of water that was then what she felt. And then she was actually much easier when she came to theatre. And the parents actually seeing that, and also the nurse looking after her, after seeing that, relaxed a lot as well. So it was actually helpful from a lot of points of view. Okay, so we're going to talk about direct and indirect suggestions. So suggestion is a communication, be it verbal or non-verbal, that leads to a subconscious change in perception, mood or behaviour. And a direct suggestion is, when you do this, you will feel this. So when you breathe in, you can breathe in some strength and control you didn't even know you had. And when you breathe out, you can feel yourself relaxing. Direct suggestion. Indirect suggestion. Most people find when they breathe in a bit of strength and control they didn't even know they had. And most people find that as they breathe out, they feel themselves relax as they blow some of the discomforts into the atmosphere. They feel their mind drift into a daydream, and they feel more and more calm, more and more at peace, more and more relaxed. That's right. Well done. That's good. And you can pace the words to as they exhale. And when we exhale to functional residual capacity, which is the most relaxed part of the chest wall. And so when you're telling someone that as they breathe out, they will relax, they subconsciously focus on the chest wall and notice FRC as chest wall relaxation. And they get a subconscious yes in the brain. And then if you say to them, each time you breathe out from now on, you're going to feel yourself relax even more. They get another subconscious yes as they breathe out. That's good. And then as they breathe out, they get another subconscious yes. Well done. And as they breathe out, they get another subconscious yes. And after about 4 or 5 yeses, they get a non-volitional subconscious relaxation response to the rest of the body. You can ask a child not to do something if you want them to do it. So this is called the law of reversed effect. So obviously if you ask a child not to do something, it's exactly what they're going to do. So for a gas induction, I might ask a child not to blow the balloon up too hard if they're not interested in breathing in the gas. And I'll just say, look, just don't blow the balloon up. And don't blow it too hard, it frightens the nurses. So don't blow, don't blow, don't blow. What are they hearing? Blow, blow hard. Don't blow hard, blow. Don't blow hard. Don't blow hard. Stop it. Double binds. When you're lying still on the bed, would you like to hold mummy's left hand or mummy's right hand? If they choose a hand, what have they told you they're going to do? Lie still on the bed. So it's a choice of comparable alternatives. Either way, they're on the bed. And there's all sorts of ways we can use double binds to give choices where there really aren't many choices. And dissociation, encouraging dissociation. When we put drips in, we call your arm the arm. So it dissociates the arm from the body. So rather than calling you're this or you're that, we can start calling it the. And pain can be exactly the same. Rather than calling it your pain, or the comfort, or the colour. So we've talked about utilising physiological responses, truisms, reversed effect, double binds. Keep it simple. Repeat the suggestion in all sorts of different ways. And metaphor. And using metaphor with children can be really useful, although you want to be very careful with the types of metaphor. We had a child where one of the nurses said the propofol felt like ants crawling up the arm, and the child was screaming all night with ants crawling up their arm after the anaesthetic. So you have to be really careful with the types of metaphor you're using. You want them to be therapeutic. Okay, let's move on. Do some practice. Let me know when you have pain. Okay, what would you like to say instead? Anybody? Let me know when you start feeling a little bit more comfortable, or let me know when you start feeling a little bit easier, or let me know when you're able to do this, or let me know when you're able to do that. So you want to have a word in there that isn't focused on what you don't want. And I often give the metaphor of, we talk about giving painkillers, something to stop the pain, something to stop the itch, something to stop the vomiting. It's like going into a taxi and telling the taxi driver, you don't want to go to the beach, you don't want to go to the hills, and you don't want to go to the CBD. They actually don't have a clue where you want to go. And this is what we do to children all the time, and adults. We're always telling them where we don't want them to go. We don't want you to vomit, or we don't want you to feel sick now. We don't want you to feel sore. I'm going to give you something to stop the pain and stop the nausea, rather than giving kids something to help them feel like eating and drinking a bit sooner than they might do, or helping the dressing. So one of the things we've noticed with burns patients is, especially Max, this 90% burn boy, he used to get extremely agitated. The nurses would say to him, we're coming to do the dressing change 15 minutes before the dressing change. And then he'd be, by the time they got to the room, he was in an absolute frenzy with anxiety and what was going to happen. Now, as soon as they said to him, they gave him no warning, and we just suggested, okay, just go into the room. And as soon as they said, then no warning, they go into the room and they says, we've just come to finish off your dressings and put nice clean dressings on while everything heals. And that was the only change that was required for him. And it completely changed the whole dynamic. So we're just coming to finish up, make sure everything's clean and comfortable and healing properly, so that you can recover quicker and leave hospital a bit sooner. And those meanings really change. Pain after surgery is such a bad word. This isn't pain after surgery. This is sensations of healing and recovery. People are healing and recovering after surgery. They've not got a spear that's stuck there that needs sorting out. They've not got, an ongoing disease. They've actually had treatment that's helpful for them. And when we put drips in, we're not doing it because it hurts. We're doing it to help them rehydrate and allow us to keep them comfortable and safe for when they wake up later on. So what about this? This will hurt, this won't hurt. What do you think of that? Sorry? They just hear hurt. So whether there's a knot in front of it or not, they're just going to hear hurt. What can you say that's not being dishonest? So if you said this will be comfortable and this won't be comfortable, they're still potentially less than truthful. So what can you say to that? There I am. Yes. Okay, let me know how you go. You may feel pushing. Yeah, so I like you'll feel what you feel. I quite like that one. Or we're just finishing up now, is that okay? We're just going to finish up this, is that all right? And if you feel anything bother you, you can wiggle your toes or have a little cough or take a breath in, and that'll just allow us to finish up a bit more comfortably than otherwise. So you can actually give the child something to do. And if it hurts, and if they say, does it hurt? What can you say? Sorry? If it does, wiggle your toes. That's not bad. That's good. Thank you. If it does, wiggle your toes. Great. Any other suggestions for that? I really like that. I'm going to use that. Some people tell me it does. Most people are surprised. It's so much easier than they thought it was going to be. So much more comfortable than they thought it was going to be. But I don't know. You're going to feel what you feel. I can't predict what you're going to feel. But let's see how comfortable we can make it. Okay. Painkillers after surgery. What about painkillers? Powerful painkillers. Okay, so there's medicines to help you feel better, possibly. That's good. We're getting there. Anything else? We're just finishing up. Look, we're going to do everything we can to get you as comfortable as possible. Now, sometimes that's changing position. That's time showing you how to do some deep breaths or focusing. Sometimes it's giving you medication so we can get that comfort under control, so we can get you comfortable. And when you're comfortable, you can let us know. And then that way healing and recovery can occur a little bit more quickly and a little bit more easily for you as you get out of bed and mobilise or whatever it is. So focusing on where do you want the child to go rather than not go. And it may just be a simple thing that, like allowing, I mean, for some kids it may be just sort of sitting up in bed or just something really, which can be quite a big thing sometimes. So it may be just a small thing that they can do. And then that can be reinforced in something you can build on. Try not to move. Stay still. Thank you. Perfect. We're going to give you something for nausea and vomiting. We're going to give you something to help you feel like eating and drinking a bit sooner, if that's okay. Okay. And in fact, if people pretend they're eating their favourite food as they have their anaesthetic, they often wake up feeling hungry, and that's a really nice thing to do. So often what I'll get them to do is I'll get them to describe what food they like, and then as they're getting pre-oxygenated, just get them to eat their favourite food in their mind. So just say, okay, start eating your sandwich or start eating your spaghetti bolognese. Now's the time, spaghetti bolognese time, off we go, and they start eating the spaghetti bolognese. What sort of plate's it on? Okay, how much, is it warm? Is it hot? Is it a bit cold? It's been left out a bit? What's it like? You know, and they'll give you, and we're going to talk about how to do this in a little while. This is the lived-in imagination stuff. And you can actually do surgical procedures with this technique. So the mitigating words, it only stings a bit, it's only a small needle, it doesn't taste that bad. The mitigating words don't make any difference. Try, as most of you know, is a failure word. So if you're using try in front of a negative word, you're inviting the child and the adult, in fact, to fail to do what you're asking them. Pain, of course, is a negative suggestion, hate to say, by definition. Nothing to worry about. In fact, a father the other day was saying to the child, don't panic, as the child, who was actually okay until that point, started panicking. And not, of course, isn't heard by the subconscious. So there's some really good evidence with this stuff, particularly in children with functional abdominal pain and irritable bowel syndrome. So there's been really nice research in Holland on this, and a fair bit published in Gut. And there's a lot of other stuff on language. I'm not going to spend any time on Darren here, who did some experiments, just to say that he showed very neatly. One of the things he says in the video is, I felt sharp but no pain. And one of the consistent findings of functional MRI studies is the anterior cingulate cortex lights up with a negative suggestion. So if you talk about pain, vomit, sting, hurt, that anterocingulate cortex lights up consistently and turns the sensation into suffering. So a sensation is just a sensation. Whether we suffer with it is actually optional. And we can often exacerbate our perceptions and behaviors by using negative suggestions. And you can image that in the brain. And although anterocingulate cortex is but one area, there's multiple areas that do this. It's a consistent finding in over 20 studies. And I'm not going to spend any time on this. There's a lovely study done in adults on sting and numbing in spinals and epidurals, showing big differences in pain, both pain scores and anxiety. If you use a sting word, pain scores increase, anxiety increases compared to numbing the skin to allow us to do the procedure more comfortably. So why you do things, if you're doing anything painful, if you explain the procedure in terms of why you're doing it, you're not doing it to hurt them, you're doing it so they can recover, so that they can get better sooner, so they can mobilize sooner, get up and about, do this, do that, whatever, feel more comfortable. We did a randomized trial, again in adults, but I'll just briefly run through it. We randomized 300 women after cesarean, asked them their standard pain scores versus comfort scores, how you're feeling, how comfortable are you? And in the pain score group, they were 4 times more likely to request analgesia than in the comfort group. So again, might be worth having a look at that. It was published a couple of years ago now, British Journal of Anaesthesia. Okay, this is where the fun begins. Steeple technique. So what we're going to do is, and I've got Sue and Rob to give us a hand. What we're going to do is I'm going to show you what I normally show patients in the clinic how to do this. It's a very quick, how I describe it is it's a really quick self-hypnosis relaxation technique that's about 20 times more powerful than any medicine I could possibly give you. That's how I first describe it. And most people learn this in about 5 minutes. Would you like me to show you how to do it? Well, and the majority of people, including adults, will say yes to that. Okay, so the first thing I do is I'm going to demonstrate it, then I'm going to talk you through it, and then I'm going to watch you do it without me saying anything. So it's in 3 phases, okay? So the first thing I'm going to do then is just demonstrate it, and as I demonstrate it, I'll just talk you through it. No, they're not. When you're clasping your hands and you bring your fingers up like this, the lumbricals become tense. So it's called a physiological truism, like when you tell someone they're going to relax as they breathe out. The physiological truism is this chest wall relaxation. This is exactly the same. You're telling them something that is physiologically true. The lumbricals are on the stretch, the fingers are going to come together. But because the brain doesn't recognize the physiology, it says, he said that was going to happen, and it did. And therefore, the next thing you say is more likely to be a yes to. So you're starting to develop a series of yeses that become more likely to be realized as non-volitional subconscious responses. So that's the process. Do you want to, yeah, Rob? If they don't come together, that's resistance, and that's useful of itself. And he says, and you can just very easily say, well, that's very interesting how the mind has stopped those fingers coming together. That's very interesting. You've got a very powerful mind, an extremely powerful mind, so powerful it can make you feel even stronger than we thought. So utilization, a response is just a response, and the utilization and the reframe can be the therapy. So it doesn't matter what the response is, it is the response. So no response is still a response, and that's what's interesting. So how different people do respond is interesting. Do you want to give that a quick go without me saying anything? I'll give you about a minute just to see how you go with that. And then if there's any questions on that, we can talk about it. So just give yourself maybe another 20 seconds or so of clock time, which can be as long as you like in hypnosis time. And then to get the maximum benefit, and then allow yourself to come back into the room with all normal sensations returned, awake, alert, refreshed, re-energized. Great, thank you. So, any questions about that? So what we're going to do now is to split into pairs, and one of you can be the hypnotherapist and one of you can be the subject, and you're going to practice teaching whoever you pair up with. And we'll give yourself 5 minutes each for that, and we'll come back in. I'll give you a 5, when the 5 minutes are up, I'll let you know, and we'll see how we're all going. Okay? Okay, we're just going to have some feedback and then we're going to move on just a little bit, because I just really want you to practice some lived-in imagination. Any comments on that, please? We've had some interesting questions and queries. If your hand stays up, that's fine. That just means that people have entered light trance and they've got a catalepsy. So just let them stay up if they want to. If you want the hands to come down onto the lap, you can just suggest something like the fingers can start feeling a bit slippery as the hands then separate and come comfortably to rest on the lap. So you can actually then suggest it without asking for that to happen. As you breathe out, just feel the arms come to rest gently on the lap as you breathe out, and they can just comfortably come to rest on the lap. Someone was saying that one of the things I was going to talk about, and it just reminded me, was that with practice, if you make the suggestion that each time you practice, like anything, it becomes more effective, easier to use, easier to be effective. And like anything, when we practice something, it's easier to do. And so as you practice this, you're going easier, you're going faster, you're going deeper, you become more comfortable, you become more relaxed, you feel more in control. Anything that you would like to suggest to the child, you can just make those suggestions as they practice. And there may come a point as you practice where you don't even have to move your hands. As soon as you think about it, your mind will just drift rapidly into the daydream without even moving the hands. So you can practice this as many times a day as you like, and no one will know you're even doing it. And that can be quite interesting. The other thing that you can suggest, and there was something at the back, you've just reminded me of something and I can't remember what it was. Doesn't matter. It'll come to me again when I stop trying to remember. Okay. Any other questions on that? No. Okay. Yes. Look, usually, mostly I've been using it with, mostly I've actually been using it with very, very anxious patients in the clinic when I see them before their surgery. But I think Rob's had some experience using this technique with kids before anaesthesia.
So, it's a suggestibility test. So if someone is going to give a demonstration of what hypnosis is like, without doing the full things, so they're actually anxious about hypnosis. So then use this. And then you can use it to use form of hypnosis. So you might go straight from this to a it's very relaxing. You're halfway there just a bit at that stage. You've got an anxious kid before surgery.
And you can also give suggestions for things that normally are frightening, like equipment and whatnot. So, for example, there's a few people in the room, but knowing each one's got a job for you to keep you safe, keep you comfortable, throughout the procedure for when you wake up in the recovery. That can be very relaxing when you see different people in the operating room. The other thing is when the blood pressure cuff goes up, that's a signal to you that we're keeping a very close eye on you, we're monitoring you closely, we're there with you all the time. And every time the blood pressure cuff goes up, again, it's a signal for you to be more comfortable and more relaxed, as knowing that we're looking after you carefully. Yes? No, I asked them, look, would you like to learn something that's very easy to learn, that can often helps adults and children feel more in control, feel more comfortable, more relaxed, they have a quicker recovery afterwards. Would you like to learn something like that? And then it can save a medication. Look, for the next thing we're going to do, you can go down as young as 4, but for this, maybe 7, 8, probably, and above. But the next thing, you can go really quite low, and adults as well. So the believed in imagination, you can go right to... So we're running a bit out of time, so I'm just going to go into the lived in imagination. And one of the best patients I had was about a week ago, and I think I'll come to it here, not that one. The girl with abdo pain who loved musicals, the 12-year-old with a recurrent eye tumour was an interesting patient. She was one of the first patients that I used the lived-in imagination technique on. And I came into the room on the acute pain round, and she was vomiting. She had a fentanyl PCA. She was screaming in agony, and everyone was beside themselves, the parents and the nursing staff, about what to do with her. And I just asked her, tell me about a time where you last felt well. And she told me about a houseboat trip she did on the Murray. And I said, who was with you? So I just asked her to close her eyes. The parents were there. And I said, who's on that boat, who was with you? And she said, Jack. I mean, this was like maybe 10 years ago. I still remember all the details. And I said, whereabouts are you on the Murray? And she started telling me what she was doing on the Murray. And I said, what's the weather like? So I stopped from asking her about it to asking her what was happening about it now. And she said, it's quite sunny and there's a couple of clouds there. And what can you see in front of you? And says, there's some cliffs and there's some trees. And is it warm or is it cool? It's quite warm. Any humidity? Not much humidity. And I says, and just look at what you can see and hear what you can hear and feel what you can feel and smell what you can smell. And she started sniffing. And I says, what can you smell? And she goes, lunch. Anyway, I sort of, at that point, I said, carry on your boat trip down the Murray. And pain can be very useful. Pain can tell us that there's something wrong, like if we've broken an arm or if we've got appendicitis. And you've had a very good reason to have pain. You've got your eye tumour back, so you've had a very good reason to have pain. So that was very good that your body told us that your eye tumour came back and that you had some pain. That was really useful because now the doctors know you've got pain, the nurses know you've got pain, the parents know you've got pain. And because it's done its job, you don't actually need that pain anymore. So what I want you to do is to thank your body for telling us that you had that recurrent eye tumour and that you don't need the pain anymore. And you carry on down the Murray and we'll see how you go. Anyway, she went down the Murray for another sort of few minutes and we brought her out of the daydream. And I went back to see her that evening and she'd actually stopped vomiting. So she'd had some supper, but she was still in a fair bit of pain. She still had the fentanyl PCA. And I said, this was Wednesday night, and I said I'd see her on the Friday And on the Friday, she'd actually gone home on Panadol, and she did die 6 weeks later, but she actually died without needing any analgesia apart from the Panadol. So it just struck me, it was sort of interesting that just a very simple lived-in imagination technique, and then you can give some suggestions with some trance logic of why the pain doesn't need to be there anymore. The girl with abdo pain who loved musicals, she was there 2 weeks ago, and so I'm just putting a drip. I was just going to put a drip in this girl, and I says, "Oh, now you're telling me what you like doing. You like theatrics and musicals." She says, "Oh," she goes, "Yes." She goes, she's 12. "Yes, I love the theatre," she goes. And then I said, "Okay, close your eyes." And I put the drip in. The arm was completely cataleptic. And I said to her, "What's happening?" She goes, "Oh, they're cheering as I'm coming on stage. The clapping's still going." You know, she had not noticed the drip at all without EMLA or anything. So this is a really powerful technique. And on the few minutes we've got left, I'm just going to demonstrate it, and then I'm going to get you to practice it. Have we got any volunteers? Okay, look, it's really easy. So you ask the favourite thing, and you ask them, "What do you like doing? You don't care." Walk out on the beach. Okay, perfect. So what we're going to do is a little bit of imagination of walking on the beach. So when you're ready to walk on the beach, you mind, close your eyes and actually breathe out. Just feel yourself relax. And I'm going to ask you some questions about walking on the beach in about 30 seconds. And when you feel you're there, you can just sort of nod your head. And just notice the sights and the sounds and the tastes and the smells. And tell me, what are you wearing shoes on the beach? No. And what's the weather like? Very humid but nice. And how far away from the water are you? You're close. Okay, great. Has any of the water back on your feet? No. And what shoes have you got on? No shoes. So you're just walking on the sand, really soft sand. Is it slightly wet or dry? Nice and warm. So you've got nice warm sand going on the beach. And now out to sea, can you see anything out to sea? Are there any boats or people swimming or anything like that? Okay. Beautiful sunset. So while you're walking along the beach, just feel the lower part of your body just relaxing and more you carry on walking and just go through continuous and interesting about happy moments. In the meantime, let's take up this talk to you. So, and just notice each time you breathe out how any sensations in the lower part of your body just dissipate as you breathe in and out. Just feel yourself becoming very, very relaxed and very, very happy. Great. So it's a very quick reduction. You close your eyes, take yourself there, all the way over to sights, sounds, tastes, smells, moving, everything you see is moving. As soon as you start getting very specific responses, you start adding in suggestions. And suggestions that you are suddenly very safe and relaxed and numb. I can do that way for the operations on the knee, the hospital, or whatever it is. You just allow that part of the body to take a sleep and stay comfortable while else you can't really hear what you do. How's the lower part of the body? Very relaxed. Okay. Is it okay just to come out of the bacon and then up to the lower part of the body? Would that be okay to do that? Sounds a bit weird. Okay. Just keep the lower part of the body as relaxed and comfortable as you can just now. And just allow the part of the body a lot more to come out of the bacon. So you can just feel the lips of the tongue and the mouth and the nose and the eyes and the forehead.
even with 30 seconds, we can get quite dramatic changes in perception. So what I'm going to ask you to do is so that this can be just ask you to say the deep breath and close your eyes, and then we'll just, as you do that, just feel it, relax, very calm, and when you just relax and comfortable, you can do the rest of it. Just stay there for about 30 seconds, and then you know enough people to talk to your mind, and you can tell yourself that you know what most of you are awake, and relatively fresh, and you realize that all the sensations return. You tell yourself that you know hypnosis, and you're awake, and relatively fresh, and you realize that all the sensations return. As you go to that happen, you tell yourself that you know hypnosis. Okay, now I don't want you to do a body anesthesia with dissociation, but what I would like you to practice is just this, would it be okay to engage in an experience where you close your eyes and just go to a place that you really like to do, so you feel comfortable and relaxed, and I'm just going to ask you some questions about it. Can you just spend maybe 10 minutes doing that, maybe 5 minutes just asking some questions. Now, the questions are non-leading questions. What's happening? What can you see? Don't say, oh, there's a boat there, what, you know. So it's, and it can, so I think the thing here is not to suggest or try to imagine what the other person is doing. It's actually asking questions about the experience so that you engage within the experience. Okay? Any questions? You've got 5 minutes. Sorry. Oh, okay. We're going to do a very rapid one, 2 minutes each.
Okay, just going to reorientate yourselves over the next 10 to 20 seconds, please. And I'll just show you how you can use this lived-in imagination technique again with a Burns dressing that you've had at school.
Splash day.
Splash day. Tell me about splash day.
We get to go swimming.
You get to go swimming. You're swimming all day.
Yeah.
Tell me what you were doing.
The water slide.
The water slide.
Yeah.
And what colour was the water slide?
Blue.
Blue. And how high, how many steps did it have on? Do you remember?
Heaps.
Heaps. And do you remember climbing up all those steps?
Yeah.
And then what happened?
I went down.
You went down. And did you make a really big splash?
Yeah.
A really big splash? Excellent. And and how many times did you go up and down that water slide?
10.
10. And what was the best time? Was it the first one? Was it the third one? Was it first was the best? So you did that, and you kept going up, and then you kept going down. And when you made a big splash, what did it feel like?
Fun.
Fun. Excellent. Well, why don't you just now go back to your favourite time on the slide, and you just feel yourself there, playing with Brock and the others, and then we're just going to carry on here. So that's it. I'm just going to, get to the very last slide. Tell me about... No, I sort of put some notes in, but I ended up not using it. So just get really quick, as usual, no time. So that's one of the summaries is often it's whether you think you can or whether you think you can't. You're probably right. And so the ABCs appreciate these communication structures, the conscious subconscious responses. Patients can always do more than you think they can and more than they think they can. And control and choices are really important. If there's any questions, email me. I'm happy to answer any. Thanks very much for your attention.
Allan, I think that was a really fantastic way to finish the day, so thank you very much for that. So Allan will be there at dinner tonight, so rather than have questions tonight, questions now, we'll have a glass of wine and talk later. And I've been told by Tracy we need to finish straight away because at 5:05 there are the discipline subgroup meetings until 5:30, I believe. So we'll close. Thank you very much, everybody, for a really good day. And you'll all be getting feedback emailed to you. And if you can please write any ideas or feedback, ways that you would like the pre-conference workshop adjusted or other things for Sydney.